Hi everyone, myself Dr. Priyanka, and I am one of the mentors for Study EFOG. So we are back again with the SSS YouTube series part 2. So where we will be discussing the important questions for the EFOG OSCE exam. So do like, share, and subscribe Study Medic channel, and also press the bell button icon to get the updates on the recently added videos. So today we'll be discussing our topic will be cases of difficult patient or an angry patient. So this is the most one of the most important tasks where which tells how you communicate with the patients and their relatives. Also, how are your communication skills? So do remember that the only difference between success and failure is the ability to take action. Okay, so believe in yourself and keep practicing, and definitely you will succeed. So we will first discuss the case, and then we will discuss the essentials of passing this difficult patient or relative station. So how to crack this station easily. Okay, so we'll first discuss the case. So first I will tell you the scenario. So this is a case of a primary gravidia who has come with a 24-hour history of decreased fetal movements at 39 weeks, and then she was been classified as low risk, and then it was confirmed that it is an intrauterine fetal death. And first, she was told that everything was normal. Now her husband is angry and he has come to meet you. Okay, so I will be playing the role player, that is her, the Mrs. Tina's husband, and also the doctor. Okay, so let's start. So, hello, I'm Dr. Priyanka, one of the doctors in the clinic today. So, in the ward today, may I confirm your name and age, please? Yes, I'm John Chu, and I am 34 years old. So, how can I address you? So John would be fine. So, John, I can gather that your wife has delivered, and you have come here to talk regarding the same, right? Yes, I want to meet the consultant. Where is he? So, sorry, John, but our consultant is not available at the present moment because he's attending some emergency. So, John, is it okay if I ask if I talk to you, and then I can arrange an appointment immediately with him as soon as possible? Okay, but I definitely want to meet him, and I don't know. I have to complain him everything that has gone that in these 2 3 days has happened. Sure, John. We will help you in your whatever any complaints you want to file. We will definitely help you. But John, as we are meeting for the first time, can I ask you a few questions, and then we can come to a management plan which is beneficial for both you and also Tina? Yes, sure. So, first of all, John, can you tell me please how is Tina? How is she coping? Yeah, she's in a shock. She literally doesn't know what to do, and she's just blaming herself for the loss of our baby. I really don't know what to do now because it is very difficult. She's just crying, and she blames herself because she thinks that she's the one because of which she's John Peter is not there with her today. I can see that you are really disturbed, Mr. John, and also Tina must be disturbed. But don't worry, we as a team of doctors are there here to help and support you, Mr. John. Yeah, let's see. So, Mr. John, please can you tell me does she have any complaints of any excessive bleeding or any pain, anything? No, she's not having those complaints. So, blood doctor, please tell me why this happened, because we had come just one day before, and because she was having some pains, and the doctor on that time, or the doctor on duty told that they removed some baby's heart trace, and then they told that everything is normal, and they just sent us back, even though she was not feeling well. She was having some pains, and then after today we came, and then we came to know that she's had the babies no more. How this happened? Why sudden the changes happen? Because we were told before 24 hours that the baby is normal. Yes, John, I can see that you are really disturbed because of this loss. But sometimes, even after our best efforts and best management, sometimes uh, mistakes do happen, and we are sorry for that. So, what can be done, doctor, now? So do not worry, Mr. John. We will go in deep into this matter, and we will look what was wrong. And there are specialist team of doctors in our department who specially looks over these cases, and they will look at what went wrong and what was the reason that it went wrong and who were all involved in the process. And they will have a meeting on that, and the results of the report will be transparent and they will be conveyed to you, Mr. John. Okay. So please tell me then what was, because then we came to know that our the baby was also weighing less. Why this was, why it was not picked before? So yes, Mr. John, I can see from the reports that the baby was weighing 2.3 kgs. So yes, the baby was quite less for the 9 months of amenorrhea. But still, if you allow me, Mr. John, can I just have a look at Mrs. Tina's report, and I will also ask permission from her. Is that okay, Mr. John? Sure. So that I can come to know that where the care has been suboptimal. Okay, Mr. John? Yes. So, Mr. John, can I ask you a few questions regarding Mrs. Tina? Sure. So, can you tell me how was her pregnancy, the current pregnancy? So, yes, we were like trying, this was our first baby, doctor, and everything was fine. And we had follow-ups with the midwife and also the GP, and they told us that everything is normal, and she can have even home birth also. They told us like that the baby is growing well, they told. And they just did one scan, I guess. And even we were asking that is there any need to do another scans, they told that there is no need. This is fine, the baby is growing well. And if all the things were fine, but then she came 24 hours before because she was having the pains. And then later they told, the doctor on duty told me that the because we were referred from the midwife, the doctor told that the baby's heart rate is normal, and they sent us back again. And now see, now the baby is no more. So where is the fault, doctor? And then we came to know that there was also a cord around the baby's neck. Yes, I can see, John, that you are really disturbed. But the cord around the neck can also be the cause, and also sometimes can be the incidental finding for having the fetal, like that can be causing the fetal death. There was one look, but yes, it can be an incidental finding. So, so John, can you tell me, did Tina had any history of high BP records anytime? No, no, doctor, not during the pregnancy. But then when we admitted her, they told us that the BP is slightly high, and also they did a urine test. They told that there are proteins also in the urine. Okay, okay, Mr. John. And Mr. John, can I ask you a few personal questions regarding Mrs. Tina that may sound intrusive, but that will definitely help in the management plan? Yes, sure. So, did she smoke or take alcohol or recreational drugs? Yeah, she was worried. She is kind of very she gets anxious easily. And during the pregnancy also she was very anxious. She was every time she used to think that like there is something problem with the baby, that the baby there may be some harm to the baby. That's why, because of that intention, she used to smoke cigarettes, 10 cigarettes per day. And so, okay, Mr. John, so had she ever thought of quitting smoking? No. Okay. So, otherwise, any other problems? She had any other medical problems, or she had any surgeries? No, doctor. Okay. And did she feel any kind of depression in the last few weeks? No, doctor. Okay, Mr. John, thank you for giving me all the information that I wanted. So coming to the reports, John. So yeah, I had confirmed the baby's name and the Tina's name, and it is their reports, and we can see from the reports, John, that the results of the baby's tissue reports, that they are all normal. Okay, so they have come normal. They checked if there are any birth problems in the baby, but they were all normal. The only thing was the baby was weighing the only 2.3 kgs, which is quite less for 39 weeks baby. So, doctor, you mean that our baby was really not growing well as we thought? So why they didn't do the scans in the during the pregnancy, so that they could have picked up earlier? Yes, your concerns are justified, Mr. John, but yes, we will look into this matter, and the results of the report will be conveyed to you that what went wrong. Okay, doctor. So what can be done now, doctor? If all the thing was normal, only the baby was weighing small. So not many babies are there which weigh small, and but they don't die in the womb. Yes, sir. Yes, certainly, Mr. John. But as you said, that her blood pressure also had raised during the time of when she came with that the feeder is not moving well. So maybe the blood flow also would have become less to Peter, and that's why it would have led so to some this unexpected outcome. Okay, so what can be done, doctor? So, yes, we as a team of doctors are there here to help and support you, Mr. John. And from next pregnancy, so it will be considered as a high risk pregnancy because she had loss of pregnancy and also her blood pressure had risen. So that's why it will be under a consultant led care. And also, there will be a specialist team of doctors looking over her, like my consultant, and also the baby's doctor, the pain doctor, the midwife also, and also the GP will be kept in the loop. And also we'll be doing proper we will be starting her doing a dating scan, that is the scan to correct the check the dates of the pregnancy. And the same time we'll be starting her on the vitamin called as folic acid. And then also we'll be giving her and a tablet called as baby aspirin, which will prevent her blood pressure and also cause prevent the proteins in the urine from coming. And also will prevent the baby from growing small. So these are the strategies we can do in next pregnancy. And then we'll at each visit we will be calling her and checking her weight and also checking her blood pressure and also checking her proteins in urine. And the baby's growth will be monitored by scans serially in the next pregnancy, Mr. John, because she had a previous history of having baby small. Am I clear, Mr. John? Yes, doctor. So and also she will be also, as and I know, Mr. John, that this is the loss is very much has created an impact on you. So for both of you, I can refer you to the psychological counselor where you can share your views with them, and they will definitely help you. Okay, okay, doctor. So when can I meet the consultant? Yes, definitely, Mr. John. So in the meanwhile, I will connect with my consultant, and he will be seeing you in a meantime. Okay, doctor. And if I want to complain regarding the hospital, because this in this era this shouldn't happen. That this is really substandard care. This shouldn't happen. Yes, Mr. John, I value your concerns, and yes, if you want to complain, I will connect you to the PALS, that is the Patient Advice Liaison Service, where you can complain. But I just want to tell you, Mr. John, that we will deeply look into this matter, and the results of the report will be conveyed to you. Okay, doctor. So, do you want any concerns, Mr. John? You want me to answer your concerns? Any other concerns you want to share, Mr. John? No, doctor. Thank you. Thank you so much, Mr. John. Yeah. So this was regarding the difficult patient where the baby was small, had grown small around 2.3 kgs, which is quite less for a 39 weeks of gestation baby. And also the patient had a first spike of probably she had a not was compliant with the follow-up, and also her blood pressure had risen at the time when she had decreased fetal movements. So and also her husband is angry. So this is a case where there is the patient is angry, and also you have to manage the difficult patient. So here the main thing is to introduce yourself properly, and also apologize that the consultant is not there around, but you can tell that he is attending an emergency and he will be meeting soon, so that they will get they will calm down. And if you tell them that he will definitely meet you as soon as possible, so they won't have any problems with that. So here, this as it is a difficult station, so difficult patient station, or because the patient may have some loss, or the patient may hear some bad news, like hearing the news of a cancer, or sometimes they may have treated for a cancer and then the surgery was suboptimally done, and then the margins came out to be positive. So these are the some of the few examples of this station. So here we do not have to become defensive. Okay, so we have to apologize to them, but not frequently. Okay, and also we have to calm down ourselves even if they are aggressive. Okay, and we have to let them talk, either the patient or the relatives, and we do not have to interrupt them, so that they will also think that we are giving importance to what they are saying. Okay, so here the approach should be sympathetic, empathetic, and we have to talk properly in a calm tone with the patient, not loud voice, and our face should also be kind of because you cannot smile in this case. In these cases, it's not a happy thing, a happy station. So here the face should be either a neutral or a calm, and quite serious environment. Okay, so here we have to first initially ask, how is the wife doing, because they should also know that we care for the patients, and also how are they doing, how is she, does she have any bleeding, how is she, does she have any pain, and if they are having any pain or anything, so we can offer them painkillers. We have to maintain eye contact, that tells that we are true, whatever we are speaking, it is true. Okay, and then we have to try to diffuse the anger. We do not have to be defensive, because that will again, they will be more angry if you try to defend yourself, that this is not our fault and we don't know why she was smoking. So you cannot tell like that. So we have to diffuse their anger, we have to listen to them calmly, and then we try to defend when their anger. So then dealing with the case, so we can see from the clinical scenario that the fetal was growth restricted. Okay, so yes, definitely the antenatal scan should have been done during that time, and the patient, if then FGR was detected, she should have been referred to the consultant-led care. Okay, so that was not done. So that will be done by the risk management team to know the cause. Okay, and here also the fetal growth restriction, the most probably the cause would be her blood pressure, which she had a preeclampsia. Also the proteins were 2 plus, and also the patient had a history of smoking 10 cigarettes a day, which can also is a risk factor for fetal growth restriction. So that could be the cause in this case. And also cord around the neck can be causal or incidental. So here we have to explain this to the patient in a sympathetic manner, without showing any that they are responsible for the baby to grow small, or anyone. No, no blaming should be approached here. No blaming of colleagues that they did not do the scans. No, here it is like the specialist team of doctors will be looking over the case, and the results of the report will be conveyed to them. Okay, so there should be any no blame approach. And then we have to explain the postmortem findings, that everything was normal except the weight of the baby, and probably this could be due to the high blood pressure. Okay, and next, future pregnancy plans, as she had a history of previous fetal growth restricted baby. So in this pregnancy also, we will start her on next pregnancy on the low dose aspirin from 12 weeks. And also we will check the risk of preeclampsia by doing the uterine artery Dopplers, the folic acids, and serial growth scans. Okay, starting from 26 to 28 weeks, to look for the fetal growth and Dopplers. And also we will do the anomaly scan. And at every visit, we'll be checking the blood pressure and proteins in the look for proteinuria and weight of the patient. Also sensitively cover the part regarding the smoking habits. Always signpost that you are going to ask some personal habits questions. So always signpost before asking these questions, and if they are smoking or drinking, calmly and sensitively tell them that how it can be harmful to their general health, and also to the risk to the fetus. And then you can encourage them to stop smoking by referring to the stop smoking services. Then coming to the as I said, that not to incriminate colleagues, not to blame that he was responsible, or I was not there at the time of when you were sent back. So not to do never incriminate the colleagues, and there should be a no blame approach. Okay, and you can tell that even the standard of care was good, sometimes the care has been given is good, but sometimes the patient may not satisfy with the care that you have given. So sometimes yes, not all patients will be happy, but you can tell that in spite of giving proper standard care, sometimes yes, do the patients feel that we are not up to the mark, but yes, we will definitely keep on working and give proper service. So here you can, of course, connect them if they want to complain. They can connect them to the patient advice and liaison service, as we did in the station. If they want to complain, you cannot tell that you cannot complain, or you have to wait to admit the consultant. Yes, you can definitely guide them to the complaints procedure. And also you can connect with the follow-up visit with the consultant, with his wife, and him he can discuss with the consultant regarding the further management plan. So here, what was there in the information gathering is to review her notes, exactly what happened, what was the sequence of event that led to such circumstances, and also the results of investigation that we discussed, which came normal, and also the general health and how is she coping, and referring them to the counselor is very important, and what are the current medications and allergies in every station is very important, which needs to be ruled out. And also you have to introduce yourself and also confirm the patient's identity. Also on the reports you have to confirm the patient's identity. And also here we have to look that we have to look retrospectively what was the course of events, how did the patient receive the antenatal care. And also as they had a loss, we can refer them to the bereavement services and also support groups like SANS, and also psychological counselor. And we can outline the plan for the next pregnancy. So here, communication with colleagues part is very important. So we have to liaise with the clinical psychological counselor, and also we have to connect to the GP, and also the social worker and the midwife, to so that because the further follow up of the patients will be mostly with the GP. So having the teamwork is very important. And also we have to knowing the allergies is very important, and also the home visit should be planned by the midwife or the counselor. And also here we have to tell the patient what was the likely cause of the intrauterine death, and also very important is to tell the recurrence. Okay, so in this case, if the preventive factors are well managed, like if she stopped smoking, the blood pressure is well controlled, optimized, then and also if the treatment factors, like if she started on aspirin, then the chance again of having a fetal growth restricted baby, if she is managed in a proper consultant led care, and proper follow-up is done, then the patient will have less chance of having an intermittent death again, can be explained to the patient. Okay, so coming to the difficult patient, so here it is a very common scenario in the real practice also, because it's a common scenario, because if we when we come across a patient who is asking, it is like some patient want to have a specific treatment plan which is not standard, which is not recommended, also is a kind of handling a difficult patient, because they want to have some specific care which is not standard, and they will be consistent for that. We want to have this kind of care. Like what are the examples of that? Like requesting a sterilization if she is just had delivered one baby and she wants to requesting for sterilization, or if there is a breech baby and the patient is asking for a vaginal delivery, because we know that after the term breech trial that there is the there are many complications in the case of vaginal delivery for breech presentation, and hence the best mode of delivery for a breech presentation is a cesarean section. So those who are adamant and they ask for vaginal delivery, so that is the case also station for handling a difficult patient if they are requesting for vaginal delivery, and also requesting for home birth, and also also requesting for hormonal replacement therapy, those who had a history of breast cancer. So these are the examples of stations which where we deal with the difficult patient. Here, a patient can refuse a standard recommended plan, like the standard plan for breech presentation is mode of delivery is cesarean. So here, the patient can refuse that they do not want to have a cesarean delivery and they want to have a normal. And also they can have other non-expected management options, like here if there is a case of ectopic pregnancy where there is a viable pregnancy, there is a heartbeat, and also the beta hcg is more than, for example, 5000, and the patient is hemodynamically she has pain, but still the patient is asking about expected management or a medical management, which is not the standard of best practice. So these are the cases where you have to handle a difficult patient. These are the examples. So it is very important that we do not forget that time is limited in this kind of stations, or we have only 11 minutes to perform and complete the station. So there is much pressure. You have to cover all the history part, examination part, and also giving the management part. Plus we have to diffuse their anger, because and also we have to come to a mutually agreed plan with the patient. So that's why the time is limited, and we have to be specific with the history taking. Okay, so the history should be very crisp. And also, but even after we have to respect their wishes, the patient and the relatives wishes, but also we have to keep in mind that also we do not give them the care plan which is what they want, but it is not the recommended, which is not the best practice. So we have to come to a mutually agreed plan where they receive the best practice, and also which is beneficial for them. So even despite this, still the patient may not get convinced with you, and also they will keep on insisting that they want to have their own plan. Okay, so in this case, what you can do is, you know that you are limitations of an ST5, and here you can refer them to the consultant meeting. Okay, so you can talk to them, and you can tell them that yes, if they insist on the same plan, so they can tell them that they can you can arrange a meeting with the consultant, and he or she is the best person who will tell the decision regarding the uh, uh, plan of the patient. Okay, so this you can tell, that you can refer to the patient in case of the patient, if he or she is not agreeing. Okay, so how to deal with the difficult angry patient or angry relatives. Okay, so here that is also a skill. Okay, and here nowadays the healthcare environment may encounter this kind of situations, and also in the exam there will be patients who stations like where the role player is really angry. So they may become angry for an n number of reasons, like they have left to the waiting time is long in the clinic. Because of that they may get angry, and also some error has been made by the medical or surgical team, like in this case, and they received some bad news as they were not expecting, and their expectations are not met, so due to substandard care, so they can become angry for because of that. So these are some examples. So here, how to handle the angry patient is, you must always show empathy. Your tone should be low, okay, while managing the angry patient, and you should be sympathetic. You should have eye contact with them. You should reassure them, and tell an apology, even if you were not the one who had care for them, but you are the one who are talking right now. So you can have give a one-time apology. And also your behavior should be professional. The body language should be professional. You should maintain a calm relaxed posture, and also uncross your arms and legs, and also with both feet on the floor, as you can see with the medical professional. The tone is calm, her like she's maintaining eye contact. And also you have to stay composed, speak slowly and clearly, and do not raise your voice if the patient is shouting, because that will again worsen the scenario. Okay, and also you have to actively listen to what patient is saying. Okay, and also you have to maintain eye contact. You have to nod. You did that. Nodding means that you are listening to the patient. And also conduct verbal responses. You have to give some response to what patient is saying. Okay, and allow the patient allow the patient and the relatives to completely vent their anger. So if you interrupt them in between, if you tell them that to keep quiet, or if you raise your voice, so that will again worsen the scenario. So tell that let them to completely vent their anger. And then you can tell them that whatever you do, the results will be transparent and will be conveyed to them. You have to make sure that you have to tell them that you will do your best efforts, and also you will all like stand always you will always help them. Okay, and it will be a like non-judgmental approach, and the results of the reports will be transparent. Okay, and then it will be conveyed to them, and care will be taken. Okay, so that should be done, and excellent communication skills should be there. Okay, so here, what are the tips for in general for the station is, every station is, you have to understand which module it is. Okay, either it is a maternal medicine or which module, postpartum module, and what are the domains asked, how it is like communication with the patients, relatives, patient safety, what to do in the information gathering, and what are the applied clinical knowledge that is important in that specific case is very important. While taking a history, always it is better to ask open-ended questions. So, for example, if you are asking about pregnancy details, so rather than asking, is it your first pregnancy, do you smoke, or do you had smears, rather than asking these close-ended questions, you can ask, so Mrs. Tina, can you please tell me more about your current pregnancy, so that whatever the and any important things are there, the patient will tell, because they have the script with them. Okay, if you ask close-ended questions, they will answer specific to your question, and the main important history part, which is there is sometimes will be missed. Okay, so ask open-ended questions, and also offer to examine in the patient. Always examine the patient, especially in the presence of a chaperone, which is very important patient safety point. Okay, there should always be a chaperone in the form of a nurse or midwife. Explain them the diagnosis and in the lay language, and make sure that they do understand. Okay, check their understanding in between, and discuss the management options. So if we are giving some bad news to them, pause for a second and offer some tissues or water to them, and let them give time to them. That's it. Okay, and always communicate with the health professional. That is also very important. So as in this case, communicating with the GP, midwife, okay, for further care of the patient is very important. So in exam, the reading time is 1 minute and performance time is 11 minutes. So in 11 minutes, you have to start the session and finish a talk and give the management to the patient. Here, there are few examples of the difficult patient tasks. So what are the examples? It is the labor ward, recurrent episodes of decreased fetal movements. The patient has come and it is unattended by the doctor, the senior doctor, and the patient or the husband gets angry, or any breaking bad news, or if there is a case of a retained swab. Okay, so this is a never event. This should never happen. Okay, so it would during the labor, it was mismanagement during the labor, and there was a retained swab, and then when the patient goes home, she comes to know that there is some swab which is there inside her body. And if there is an undiagnosed breach in labor, so this is also shouldn't happen. So why if the clinical examination was not done properly, or no like why it was not picked up during the ultrasound or clinical examination, and when the patient was admitted in the labor, why it was not examination or an ultrasound was not done in labor. So this is the case of undiagnosed breach in labor. And a case of post-operative, the patient was operated for breast carcinoma, and after post-op, the report of his histopathology report comes as positive margin, and also a teenage pregnancy who has a contraceptive failure. So these are the cases where the patient will be difficult and angry. Okay, so managing them is a skill and a difficult task, which can be managed properly if the managing doctor is calm and empathetic and handles the situation in the right way. So this was us all about the difficult patient task. So thank you so much for attending the session. Thank you.